anesthesia that we look for that you guys can look for as kind of red flags, so things either don't slip by or you can kind of see what we're concerned about when we're PSTing someone. So of probably the lead thing in that is try to use your nursing skills to try to do kind of like a phone interview to kind of assess what their clinical status kind of is. You're really kind of the gatekeeper as far as this goes. You're the first interaction that they have outside of the surgeon and their own primary care physician and stuff. And a lot of these people, frankly, don't know what their medications are, why they're getting them, why they're taking some of them, whether they should be taking them or not be taking them. So from that standpoint, you can kind of be a gatekeeper and look at it and say, like, okay, well, these are things we need to pay attention to. You know, when they talk to me, if they say they don't have hypertension, but they're on a beta blocker, a little bit of a red flag. Okay, well, why are you on that? Do you not really have high blood pressure? And that can kind of open up a little bit of discussion for some of these people who really just walk into their physician's office, get told these are the medications we're going to put you on, and they leave. And they really don't have a lot of thought about what's going on with their own health. Second is medications. So from the medication standpoint, when I look at a chart, I look at the past medical history that's in the chart and just really brush through it really quickly. What I use as my past medical history is a medication list. I look at a medication list and I read the medication list, and as I'm reading it I go, okay, diabetic, hypertension, coronary artery disease, sleep apnea, whatever it happens to be, and I name those things off to them. So you got diabetes, so you got high blood pressure. And if they say no, then I look at it and go, well, why are you on Toprol? So, and that's what I use as my honest to God past medical history is medications they're on, because if they're on it, they should be on it for a reason. And then you can kind of delve into that a little bit. So I know an issue we've had is BMI. BMI cutoff for here is 42, but the way Tom and I really look at it is what's the surgery being done? Do they need general anesthesia? How much are they above 42 on the BMI scale? And do they really have any really physical ailments on top of that? So if they're a smoker and they've got COPD or they've got coronary artery disease and they've got a BMI of 42, I'm more worried about that than someone who takes just a little bit of hypertensive medication and has fairly well controlled diabetes and is a 42. So when you look at that from a standpoint of where they fit in the BMI cutoff, look at it as the first of a red flag going, okay, I know this person's going to be big and they're getting general anesthesia, but what else do they have? And then from the way that things have been going, we're just going to keep looking at those as a case-by-case basis. So if they're above 42, we'll look at it as a case-by-case basis. Typically, anybody who's 50s and above and general anesthetic, probably not a really smart choice. 50s and above, for pain patients that are just going to get a MAC or a regular MAC, probably not too bad, especially if they've had it done before, and we can just use less medication, keep them a little bit more awake. There's other ways to do it. All right, so the big stuff. So when I think about PST or I think about evaluating a patient, I break it down into systems. And from the standpoint of an anesthesiologist, the systems are not even every system. So when we look at it, we're looking at cardiovascular, we're going to look at pulmonary, what else do I have written down here? Renal, which is just one to always have a good sense about when you're given medications. Endo, and neuro and neuromuscular. We'll just call that neuro all together. All right, so from the standpoint, for me, one of the most important ones is cardiovascular. So when you look at cardiovascular risk factors, have they had an MI in the past? When was it? And what intervention was taking place because of it? Did they get a stent? So you got stents, pacer, or AICD. So those are typically things that happen when a person's had an MI or has been close to having an MI, and you want to know when. How long ago was it? If it was within a year, a little bit of a red flag. If it was within a month or two, big red flag. Okay, those patients typically won't be coming here. But that kind of gives you, right off the back, that gives you an idea of where they are cardiovascularly wise. Then you can start to look at, do they have angina? And angina, and these are the ACHA, AHA guidelines. So if their angina is controlled, which means they can walk out to the mailbox, they get a little bit of angina, but it's always kind of been that way. It's never been any big deal. Maybe they pop a nitro and it all goes away and it's not any worse than it's ever been. That's controlled. And that's a fairly poorly controlled. But if they do that, then I would call that controlled. Uncontrolled. These are our patients that we're going to cancel. So do they get angina sitting around? You know, so if they walk out to the mailbox and they get some angina and they, oh, it's the same old thing, then your next question should be, do you ever get angina just sitting around watching TV? Because if they get angina sitting around watching TV, not a good sign. So that would be a reason to cancel someone. CHF, and all these are going to come under your first question about an MI, or when that MI thing jumps out at you, that's what you're going to be thinking. So CHF, controlled or uncontrolled or exacerbated. So if a person, if they can lay flat at night, they're very well controlled. If they need a few pillows at night, but they're usually breathing okay, they can take a couple flights of stairs, that kind of stuff, then they're going to be fairly well controlled. So I always look at, can they lay flat and can they walk around without getting too short of breath? And then exacerbated is anybody else. Now another thing I will always use is METs. Do you guys understand what metabolic equivalents are? So what we're looking for with, I'm going to take that as a no. What we're looking for is 4 METs. So 4 METs is equivalent to being able to walk up 2 flights of stairs without chest pain or shortness of breath. Now that's baseline, that's a healthy person. So anybody below that, if they can walk 1 flight of stairs, that's 2 METs. If they can walk the equivalent of about, I think it's 100 yards or less, that's about 1 MET on a flat surface. And that kind of gives you an idea of what they're actually able to do. If anybody's below, a MET or below, those are people we're looking at more carefully. Okay. So from the standpoint of metabolic equivalents, those are going to be pretty much encompassed by your cardiovascular and your pulmonary side. So the reasons that they have decreased METs is because of either pulmonary or cardiovascular reasons. So that also gives you an idea. Maybe I need to delve into this a little bit more. What would it be important for Matt or Tom or Yana or whoever to see at this chart immediately, you know, or like when they're reviewing it so that it doesn't fall through the cracks, because that's our whole purpose here. So COPD, there's exacerbated and controlled. So are they on HOMO2? If they aren't on HOMO2, when do they get short of breath? How many METs do they get short of breath with? Stuff like that. Asthma. That would go here. So how controlled is their asthma? For me, my 2 big questions with asthma are, have you ever been hospitalized or to the emergency room? If they say yes, I say when. If it's been within a year, I want to know how controlled they are and what medical changes have been made to get them to the point that they haven't been for a year. If it's been over a year or so, then I usually say, what are your triggers? You know, if they've got a bad asthmatic, or have you ever been on prednisone, you've been on a steroid for it. Those are all big things to kind of go, okay, this is more than just your run-of-the-mill asthma. Renal is pretty straightforward. You know, we're going to get people here sometimes with end-stage renal disease and hemodialysis, but those are the things you really want to know about. Chronic renal failure, how bad is their chronic renal failure? Are they being evaluated for hemodialysis? But for the most part, that's not going to impact us a whole lot. It may impact some of the medications that we're going to give in the back, so that they don't stay in the PACU for like 10 hours while they're metabolically changing over those medications so that they can actually wake up. But from that standpoint, just want to know if they're renally bad. Neuro, so TIA and stroke. When was it? Do they have any residuals from it? I'm sorry, that's terrible. And if so, what are they? What kind of interventions were taking place? Do they have stents in their brain? Was it high blood pressure? Was it an ischemic stroke? You know, what's going on? Was it carotids? those kind of things. And those are the things I think of when I hear that. Now, along those same lines with neuro, we're just going to toss in multiple sclerosis and muscular dystrophy. Okay, those should always be a bit of a red flag for anesthesia. We're not going to ever do neuroaxial anesthesia, so multiple sclerosis I'm not too concerned about, other than if they've got bulbar symptoms, like they've got difficulty breathing, something like that. Anything that's going to affect them from a pulmonary standpoint. They can also have some conduction delays because of demyelination, and so some of those can cause problems with heart rate or their ability to withstand stresses or be able to, or physical stresses, so their heart rate's going to pick up or their blood pressure is going to respond.
2 questions. So for the muscular dystrophy, it's only if they have it, not how we ask, does anybody in your family have it?
No,
you
not
don't
so
need
much.
to worry about that.
Not so much.
And then back to the asthma, how about how many, if they've been intubated before, because of the asthma?
I'm going to get, that's kind of a, just kind of a catch-all that I'm going to touch on at the very end. Okay. But, and that's just kind of a history of things that we're going to hit next. Muscular dystrophy, though, on the other hand, we do want to know if there's anybody in the family that has ever had muscular dystrophy, if they've got any symptoms of it. Typically, anybody with muscular dystrophy is going to know. And that for us is general anesthesia and some of our neuromuscular blocking agents. And those are just red flags to pick up. And then last is the history that we just kind of talked on. So what I look for is airway difficulties, ever had trouble being intubated, or they've had any type of anesthesia problems with them or anybody in their family. Now, I haven't run into that a lot around here with like MH or anything like that, malignant hyperthermia, but in the Navy I ran into it quite a bit. And so it's just one of the things to know about, and if it's checked to hit on. So from this easy, quick breakdown, just kind of the way that I think about it, and again, what we're trying to do, I'm trying to do my lecturing techniques. Say what you're going to say it, and say what you said. These are the only things from the standpoint of an anesthesiologist that I really care about. You know, there's all this other stuff that is important and is important to get through. But when you're talking to a patient, if any of these pop up in your head and you say, then it's probably worth bringing up to one of us when we're here. Because in that way, they're not going to slip through. Because the whole point of the whole PST is you're the gatekeeper. You're the person that's talking to them the first time, actually sitting down with them in an environment where they should be home, they should be relatively unstressed, they should be able to answer some questions, pull out their medications, even look something up for you if they need it, and be able to give you a little more answers than they're going to here when we're all poking at them and prodding at them and asking them 10 questions and stuff like that. So by that, we are able to get further testing if we need it, cancel them, get them sent to another facility, be prepared for whatever it might be that they're going to come in with. Last but not least, back to the medications. So since, and I think most anesthesiologists do this, since medications are really my past medical history, it's important from your standpoint, if you ask their medications and you write their medications down and you don't know what a medication does, or you're not sure about what it's used for, you should look it up. You know, because then it gives you that ability to go, wait a minute, they're on a beta blocker, but they don't have hypertension, or their hypertension is really poorly controlled and they're on a beta blocker, or they said they don't have diabetes but they're on metformin. Why are they on metformin? Why are they on a glucophage? You know, so those kind of things can tell you that there's something else there, and you can probe into that a little bit more. And then, again, if you got a question, ask us. Say, this patient says they're not on diabetes, but they're on 5 different diabetes medications.
Because most of the time to a patient, they're not diabetic once they take their meds.
Exactly, and a lot of times,
once they take
you'll see that when we're questioning a patient out here, I'll go, so you're hypertensive? They go, no, I'm not hypertensive, but they're on 3 different hypertensive meds, so I know they're hypertensive, right? They're hypertensive.
Because they're saying, because I've had that happen to me. And they said, well, I'm not hypertensive anymore because I'm on medication
But they don't understand.
No, but that means that you have it. That's why we're controlling it.
And it's not, it's not worth arguing with them about it. Just go, okay, thanks, and move on. Because those are the risk factors we're looking for cardiovascular disease. Those are the risk factors we're looking at. When you look at a person for cardiovascular disease, things that are risk factors are overweight, hypertensive, diabetes, boom, smoking, boom, family history, boom. And those are risk factors, because if you look at someone who's kind of you know, on the edge and they're old and shaky and it's an old guy and he gets around a little bit and he's got all those risk factors, the chances of him having a heart attack here when we do something to him just jumped, you know, and that's not something we want to have. So, down and dirty, quick. That's kind of the way I like to do it. Any questions?
Okay, so
Anybody?
in the communication area, so we're gonna do a high-risk assessment, and the way to communicate, because you know, sometimes we do a whole bunch at one time. When we finish that bunch, you want us to like just put a bullet it, and then grab you when you're doing your run through of the charts?
So I think if you're on the phone with someone and something comes up or you're concerned about something at the moment, you can always grab us if we're around. You know, say, hey, I've got a question. Because I think we all respond to that fairly easily. You know, it depends on the day and how busy we are running around. But yeah, I think otherwise, if it's not something that really jumps out at you, where it's like, hey, BMI, and you're gonna write 50 on the BMI, or you're gonna write cardiovascular or something like that, it gives us an idea. And then we can always come back and ask you guys. It's just a yellow sticky, we'll look at it at the end of the day.
Just flag it and then bring it to your attention.
And frankly, even if you're not here and say, you know, you go home at 3 or whatever, and you do some PSTs in the morning, and you've flagged a couple of them, you don't even have to really bring it up to me. At least this is my point of view, and I think Tom would probably feel the same. You don't have to bring it up to me personally. But if it's flagged, then I know that I need to dive into the chart just a little bit more. And everybody does their own chart reviews a little bit differently. I actually kind of look at several sections to make sure that it all kind of jives. Right. Some people just sign them off. But at least if there's the yellow sticker there, the people who just sign it off are going to go, oh, cardiovascular, I want to look at what this is. Do I need to look for a clearance? If there's not a clearance, then am I willing to clear them without a clearance? Because I can clear somebody for surgery. Right. You know, I don't need to have a cardiologist do it for me. But if they're symptomatic or they got unstable angina, then I'm not going to clear them. I'm going to send them back to their primary or back to their cardiologist.
Okay.
Maybe you answered this question. I just walked in, but how well do the surgeons screen
Not at all.
medically
It's not their job.
before? But they should. They
No.
should address heart, lungs.
Everybody's heart rate is 80.
That's
Everybody's
criteria
heart-
for admission.
No. Everybody's heart rate is 80 and everybody's blood pressure is 120 to
So
72.
they do not screen their patients.
I wouldn't say they don't screen their patients. I think they look at their patients, but from the standpoint of most surgeons that I've ever met, whether they're in a hospital setting or an ambulatory setting, they're looking to book their cases. So they're going to book their cases, and then it's up to us to filter those patients out who may not be appropriate for the institution that they're
However,
going to.
do they have some sort of criteria that you will not do them with a BMI of 60? You will not do them if they're, you know, if they had cabbage or.
They're going to leave that to the rest of us to figure that out.
They literally look and see they have to fix their arm and that's all they see.
Yeah, I know they're narrow-minded, but I thought they
Well,
had some sort of
I don't know that I wouldn't say that. I think that they're going to look at their medical history and say like, well, this surgery needs to be done. I'd like to do it here. And if I can't do it here at this outpatient center, then the system that is set up to support me and the surgeries that I'm doing is going to catch that and stop that. And that's what I think most surgeons rely on. I mean, I'm not a surgeon, so I can't really say, but when you're going through your day and you've got a block of 30 patients that you're going to need to see in a 6-hour period, you're going to move through those patients. And frankly, most of the patients with orthopedic problems need to have the surgery. There's not another option for a lot of these patients. You either have a broken wrist or you got carpal tunnel and you're losing feeling and strength. And so these are things that are going to happen at some point. And we are the people, especially you guys being the gatekeepers, to say, wait a minute, let's pay attention to this. And our job is to catch the ones who would fall through the system and be difficult in the OR or be unsafe coming out of the OR to keep from coming here. And I think most surgeons rely on that because they don't have enough time to do that. They're looking to get the surgery, get the cases scheduled because it needs to be done. And if it can't be done here, then we'll make sure that it happens someplace else. And they'll schedule it at Vassar, they'll schedule it wherever it happens to be. Yeah. And so I actually think that's the way surgeons work, and what I've seen, that's my experience with the way surgeons work, and really we're I hate using the team mentality, but we're really the whole process is a top-down process. The surgeons choose the surgeries, the surgeons figure out who needs it and when they need it. And the rest of the job is to make sure that that surgery can happen in a safe, expeditious manner for the patient. And that's what we do. I walk around and sometimes I say I'm a facilitator. Well, I kind of am. I facilitate the patient's experience from when they walk in the door to when they leave, just like you guys do. And our first interaction with them is that phone call. And we are trying to make sure that they're going to be safe and well taken care of in this environment. And this environment is a little bit different than a hospital environment because you need to be able to walk out at the end. So that's kind of where I think that's kind of where the takeaway from this is we're the people that catch all this stuff, and the high points are the systems, specifically cardiovascular and pulmonary. Those are the big ones for me. Neuro a little bit, if they've got stroke history and stuff like that. Big ones, cardiovascular, pulmonary. This stuff's always good to know, but these are the ones that are going to cancel or move cases. Big. Medication list, that is my past medical history. So if you get a good medication list, or you don't know why something's on the medication list, ask them. Because then when I go through the charts at 5 o'clock at the end of the day and you guys are mostly gone, I can see a note and go, oh, okay, well, Audrey asked why this person was on all these different diabetic meds, even though they said they're not diabetic. All right, so this makes sense to me. They're still safe to come. Like something like that. Okay. Any other questions?
Just from a patient satisfaction and facilitating them out of PACU, if they tell you in PST that they have a horrible history of nausea and vomiting post-op, can you flag that? And even if you flag it even to me, because that patient should be referred back to the surgeon to get a script for a one-time PO dose of Amend prior to surgery, which will alleviate their need to stay in PACU for hours vomiting. That pill usually is, and we're not catching a lot of post-op nausea and vomiting, and we don't do a lot of general, so it doesn't happen often.
And our generals are relatively short, so a lot of times we can kind of mitigate
volume
that.
of gas, but when it happens, like, we've had a couple that I think one Amend would have
Probably,
made a huge difference in their stay with us.
And those are things that you can put down in the portion here about treated for any illnesses not mentioned above. You can put it in the surgery list, and what catches my attention is PONB. That's all you got to write.
Because if we could get back into, even if everybody from PST is gone and somebody else is here, we could get back in touch with that patient and just tell them, now this is an option you have. If you call the doctor's office and they can give you a prescription for this pill and you can take it the morning of the surgery, and most people will jump on that because anybody who has PONV doesn't want it again. So it would really, that's a little tweak. It's not nearly as important as the cardio and pulmonary stuff, but from a satisfaction standpoint,
it's a huge satisfaction
and
standpoint.
a time in PACU.
And in terms of neuro, seizures.
Oh, yeah, seizures, I'm sorry. So if someone comes up with seizures, I handle seizures the exact same way as I handle asthma. When was your last? How many of you had? When did they begin? What seems to exacerbate it? Because some people can get seizures from flashing lights. Some people can get it from medications. All kinds of different things. So I just want to know if it's well controlled. Again, when I kind of trying to give you my perspective from an anesthesia perspective, I just want to see that most of their medical conditions are controlled. If they've got controlled medical conditions, I'm likely going to be able to do a really good job for them. It's the people that are uncontrolled with anything that you start to kind of go, okay, how am I going to do this? I got to change the way this is done. I got to figure out how to make this come out so that this patient walks in at least as good as they walked out at least as good as they walked in. Okay, that's about it though. Anything else?
Thank you, it's awesome.
All right, easy
So
peasy.
we're putting the post-it note next to where the
But you're
sign-
spending a lot more time.
like literally, you want the post-it note next to where it should be signed off on the PST.
No,
right?
stick it on the front of the chart.
Really?
Yeah. Or PST, whatever you guys decide. I'm okay with either one because it could fall off. It could fall off.
But that's, I mean, if you're PST and there is not an anesthesiologist here, I think our comfort level, that's what I'm saying, I think our comfort level would rather be a text rather than a post-it note.
Totally.
If you guys aren't physically in the building anymore, if we have a short day and you guys are gone and we're still PST.
Oh, yeah, no,
I
that's,
think
that's,
making
I think that's,
contact rather than putting a post-it note on the chart
totally.
would be a better.
Yeah, no,
Because if somebody blows by here at 5 to sign off our charts, it's not happening anymore because we're busy enough, but.
well, and I think when I mentioned the post-it note thing, it's just, it would be an easy way to go about your day without having to track me down, because I know you're tracking me down, you're taking away from the stuff that you need to do, and you guys are busy enough as it is. If you stick a post-it note on a chart and it's just kind of a, hey, by the way, or this is something I think that you might want to know about, stick it in the chart, we'll take a look at it, and it gives me or anybody who's who's reviewing that chart the pause to look at it just a little bit closer. Because if you're sticking a post-it note on it, it's telling me that you're concerned about it. And I trust your guys' clinical judgment enough to say, look, if they're concerned about it, they talk to the patient. All I'm seeing is black and white on paper. And that's completely different than you talking to someone and hearing that they can barely hold a conversation with you because they're short of breath, or you can hear them having rows and stuff, and you're like, I'm concerned. Well, why are you concerned? And then, likely we'll say, bring that patient in anyway. We'll see them the day of, but you know about it, and you can say, maybe they've got pneumonia. Maybe we should send them to their primary care physician and set their surgery aside. And those are the kind of things we're looking for. Good? Good.
Very good.
Okay.
Thank you.
Oh, you're welcome. Now I have to clean the floor.
That lamination, none of that arrhythmia stuff is new to her. She's basically non-compliant. She's my neighbor. I know her. She's as cantankerous as her asshole.
She was super nice to me, but when
No,
I
she
talked
was
to her,
like, no, they told me to take pills, and as soon as she told me to take more than 2 pills, I told her I wasn't coming back to her.
yeah, she